Hi, greetings everyone. This is Dr. Evanka. So welcome to another episode of our Science and Healthcare podcast. Today we are here to explore one of the most transformative advances in molecular medicine, the biomarker revolution, precision oncology and the future of cancer care. So for decades, cancer treatment has relied largely on surgery, chemotherapy and radiotherapy. Undoubtedly, these treatments have really saved countless lives. However, they have followed the same treatment diagnosis. They have been working in a similar way despite having differences in the biological patterns and the unique biological signatures between the tumors of the different individuals. So today we can see that there is a remarkable shift in this evolution, where we can see the shift is, instead of asking the question where the cancer originates, today we are asking what are the molecular signatures which are driving this cancer. So today we are discussing the remarkable shift which has given rise to what is being termed as precision oncology, which is normally being used so that every patient can get a customized treatment depending upon his unique molecular and genetic signature of the tumor. It's similar, think of them as the fingerprints. So as every individual has unique fingerprints, so similarly every tumor is being defined by the unique genetic and molecular signatures. So we have to find a customized or a precision or a specific pattern so as to treat that disease. So to discuss this pattern, today we are welcoming, and I am delighted to welcome one of the India's most respected oncologists, Dr. Shyam Agarwal, Chairman Medical Oncology Department, Sir Gangaram Hospital. So he is here. Today he'll be discussing last 4 decades of his, expertise, how he has been dealing with this cancer evolution rather than being, treating the patients with conventional chemotherapy, how this has evolved to the upcoming targeted therapies and immunotherapy. So we welcome you, Dr. Agarwal. For the full episode of this video, please go to YouTube by the name of Dr. Evanka. Until then, stay curious, stay informed, and above all, stay healthy. Thank you.
So basically, cancers all are diseases of gene aberrations. So they're not transmitted to your children or to your offspring.
So what information are you really hoping for, which may help you in treating the patients?
We are also getting information on tumor mutation burden, and we are also getting information about microsatellite instability.
Yes.
Better chemotherapy tools so as to kill the tumor cells early, permanently, at a time when the tumor load is 10 to the power 6 or 10 to the power 7. On the basis of a blood test, you can predict in a given individual whether 2, 3, 4 years down the line, he or she is going to develop cancer or not. Yeah. So AI is also going to be helpful in a big way to analyze the data which we are putting in for the molecular biology.
So we welcome you, sir.
Thank you.
So, sir, we would like to know, as you have witnessed, the entire evolution from conventional chemotherapies to upcoming targeted therapies and immunotherapies. So what single transformation you think is the best that can define and may pave a way for the treatment of such cancer patients?
Right. So, until maybe 20 years ago, there were 3 pillars of cancer treatment, which revolved around surgery, radiation and chemotherapy. But then in the last 15 to 20 years, this is an era of molecular genetics in which we have now tools to understand the molecular biology or the genetic alterations which are responsible for development of cancer. So we need to convey this message to our audience that all cancer patients, all tumors are driven by alterations in genes, which basically it's not usually one gene, multiple genes are abnormal. They are involved in the division of the tumor cell and then subsequently progression into various parts of the body. So basically, cancers all are diseases of gene aberrations. They are not hereditary. So they are not transmitted to your children or to your offspring. So only 5% of these patients would have hereditary cancers. 95% of the times, the cancers which we see in our day-to-day practice are developing because of the gene aberrations which we acquire during our life in those organs. For example, cancer is not one disease. It can happen in lung, it can happen in liver, it can happen in kidney. So, multiple alterations in the cancer genome occur which lead to the development of cancer. Right. So, until about 20, 30 years ago, we could not identify those genetic abnormalities. now science has progressed so much that we call it NGS, next generation sequencing, or the second term is comprehensive genomic profiling.
Correct.
So you get the tissue of the tumor from the patient's body and you put it into the equipment, and within a span of 2 to 3 weeks we get that signature,
Correct.
genetic signature of that tumor type which the patient is harboring. So this has led us to understanding the biology of cancer, what is the genetic makeup of, and each cancer is different.
Yes.
Say for example lung cancer, each patient's cancer is going to be different. The genetic signatures are going to be different. It's not going to be identical. ऐसा नहीं है कि लंग कैंसर के जीन, किडनी कैंसर के जीन और दूसरे कैंसर्स के जीन एक जैसे हैं. So even in lung cancer there will be genetic differences and therefore the outcomes are going to be different. But what has happened is that as we began to identify those gene abnormalities, people started to focus on developing targeted drugs which can rectify that genetic abnormality which is responsible for cancer development. So beyond surgery, radiation and chemo, then we have the era of targeted therapy, and the era started virtually in I think about 24 years ago, when they identified in patients with chronic myeloid leukemia imatinib, the tyrosine kinase inhibitor. So and that changed the world for patients with CML, and ever since we have never looked back. And you name the cancer type, whether it is breast cancer, whether it is colon cancer, whether it is gallbladder tumor, every cancer we have targeted drugs now. And you will be surprised to know that we have more than 200 to 300 types of targeted drugs which can target those gene mutations which exist in the tumor, and the patients can become all right for a period of time. The problem is the cancer cells are very smart. So we are only able to target 1 or 2 genes. But then, as I said, there are multiple gene alterations, and those are the ones which are responsible for escape of the tumor when we're giving them 1 or 2 drugs.
Correct.
So each cancer, depending upon the gene type, has a different life. We can go to the individual gene aberrations and the results of the existing targeted drugs. For example, EGFR drug will give you a lifespan of about 3 years plus. ALK, which is present in the, or ALK gene mutation or fusion rather, which is present in the lung cancer. We have third generation tyrosine kinase inhibitors like lorlatinib, brigatinib. People can live for 10 years.
10 years.
Similarly, ROS1. So each gene would have a different drug and a different prognosis and outcome. But we are expanding into that era of targeted drugs.
Very rightly said. I think this is very helpful for our audience here who are really looking forward to all the upcoming targeted therapies they can aim for so as to get a longer lifespan, I guess.
Absolutely.
So that would really be helpful for them. So do you think, Dr. Agarwal, when your team sends a biopsy sample to our research R&D laboratory, so what information are you really hoping for which may help you in treating the patients that way?
Correct. So, as I said, each tumor type will have a genetic signature. So when we are asking for next generation sequencing, which is a comprehensive genomic profiling, we expect the lab to tell us which are the driver mutations. So that lab will tell us the driver mutations, and therefore we will be able to take appropriate action. Number one. So when you're doing CJP and we want to do at least 500 genes. So from that we are also getting information on tumor mutation burden, and we are also getting information about microsatellite instability. So these two tools, if they are found to be positive in a given individual, so these patients will then be responsive to immune checkpoint inhibitors. So which is another pillar of cancer treatment today, which has evolved in the last 5 to 10 years. There's another test which we do when we do NGS, which is called HRD testing, that is the homologous recombinant deficiency testing, and that, if positive, gives us a clue that we can treat these patients with drugs like PARP inhibitors, because BRCA1, BRCA2, PALB2, and certain other genes can be responsible for, other HRR genes can be responsible for HRD, which is high, more than 35 or so score, and they become responsive to PARP inhibitors. So, and there are so many tumor agnostic indications. For example, BRAF gene, if that is found to be abnormal, irrespective of the tumor type, we can give them drugs like dabrafenib or tremelimumab. So, so currently, if you tell me in patients with lung cancer, we are doing this NGS upfront in all our patients. But by and large, in all tumor types, depending upon how many chemotherapy drugs or immune checkpoint inhibitors which we have, so we are performing this next generation sequencing to identify the genomic makeup of that cancer cell and then target it. So I said about immunotherapy, so which is another very, very upcoming important tool. It's not only upcoming, it's already there. And then it's made a sea change in the lives of cancer patients. So patients who have MSI high, patients who have PDL1 or CPS high positive, or who have high tumor mutation burden, so these are the patients who are candidates for immune therapy. And you won't believe that even if your PDL1 is negative, TMB is negative, MSI is negative, so we are combining immunotherapy with immune checkpoint inhibitors to enhance the efficacy of chemotherapy. So common cancers, whether it is oral cancer or lung cancer or gallbladder cancer or stomach cancer and so on, kidney cancer, in all these cancers which are common, which are the common cancers in our country, all across the globe, immunotherapy has by and large come as a first line treatment, either alone or in combination with chemotherapy or with tyrosine kinase inhibitors. So the beauty of immune checkpoint inhibitors is it activates your immune system, which was put on break by the tumor cells in the body. So when your T cells, the cytotoxic T cells, or your CD8 positive T cells, and certain other subtypes of T cells, when they get activated, they remain activated for months and years. So the difference between the efficacy of chemotherapy and targeted drugs is, if immunotherapy starts working in a given patient, 20 to 30 out of 100 patients, even in advanced stage, can get cured. They can expect to live for years together. So this was not happening with chemo. This was not happening with targeted drugs. But immunotherapy has, created a niche, a value for itself in the management of a variety of cancers. So you can even expect to cure patients with advanced disease 20-30%, which is not a bad number. So I think this is a starting point for these immune checkpoint inhibitors.
Very wise, very nicely said, sir. So will it be really good to say, or will it be a right way to say that we can just not rely on a single gene these days? It's a comprehensive overview of all the cytokines, immune cells, molecular signatures, and the protein expression, which are giving a comprehensive understanding of the disease like cancer. Because cancer is such a dynamic disease and it is evolving so well that it's very tough to capture it using a tissue biopsy. Some patients now, if I talk about tissue biopsy, they're very apprehensive that recurrent tissues being taken as because cancer is evolving. So during the treatment, what can you just explain on the liquid biopsy, which is better for patients these days rather than just relying on tissue biopsy?
Absolutely. So liquid biopsies, for the lay people who perhaps may not be knowing, that is to take a sample of blood instead of taking the tissue. And what we are looking for in that blood sample is those gene abnormalities which are present in the tumor have been shed into the blood. So blood is actually representing the whole body. So when you take, say for example, if somebody has has lung cancer, which has spread to the bones and liver, etc., you can't take a biopsy of each and every site.
Yes.
So, and the issue is that the genomics or the genes which are present in the lung may be slightly different, liver metastasis may be slightly different, bone may be slightly different. But all these tumors which are present in the body are shedding the DNA fragments or those abnormal genes into the blood.
Yes.
So if I just take a blood sample, I look at the NGS, gene sequencing,
Correct.
I'll be able to figure out that in all the whole body, what are the abnormal genes.
Yes.
So now what is the problem? Why is it that liquid biopsy is difficult to perform than as compared to tissue? So, the DNA fragments which are shed from the tumors are actually small in number. So you need a much more deeper NGS.
Yes.
So you need, ultra deep sequencing, as they call it, to pick up those genetic aberrations. So therefore, you will be able to pick them up more in patients who have extensive metastatic disease.
Correct.
So as the tumor burden in the body with the result of surgery, radiation, chemo, targeted drugs comes down, so the DNA, the fragments which are shed from the tumor cells will also decline. And therefore, there will be a little difficulty in, picking up those DNA fragments from the blood. But now, I think the scientists like you, they have become so very intelligent, so very smart, that we have the technology now
Yes.
to even pick up, the gene abnormalities from less than 5 to 10 nanograms of DNA.
Correct.
So,
Very right.
no, we call this as a circulating tumor DNA or ctDNA, and this science is really coming up in a very, very big way to look at minimal residual disease.
I was coming on to that. Yeah. Please
So, the first thing is the role in diagnosis of a patient who has advanced cancer.
Yes.
So, in a patient with lung cancer, you do the tissue.
Yeah.
You say 60% of the patients get gene aberration.
Correct.
But if you do liquid and tissue, 15% more will be able to know that what gene is abnormal. So there is a gain of 15%.
Of course.
And therefore, instead of 60%, 75% patients are going to get the benefit from targeted drugs. So that is the diagnosis. So now the role which is emerging now is in the detection of minimal residual disease. So what is minimal residual disease? Minimal residual disease is that you can pick up the DNA fragments in the blood by liquid biopsy. Imaging is normal.
Okay.
PET scan is normal. MRI is normal. CT scan, ultrasound is normal.
Right.
And therefore, you can pick up the DNA fragments even when there's a very small amount of tumor present in the body.
Yeah.
So actually, and then you can treat these patients early, then as compared to waiting for imaging, abnormality to appear. And there's a lag time of almost 9 to 12 months. So, you get that 9 to 12 months early, you can intervene.
Yes.
But this is evolving at this point in time. So, if you want to get a little bit more into the cancer biology, so normal, lung cancer, kidney cancer, breast cancer, etc., they have a doubling time of almost 3 months to 4 months, 90 days to 120 days. And with this doubling time, in order for them to become 1 centimeter, it takes about 4 to 5 years.
Okay.
And in that 1 centimeter tumor, there are 1 billion to 10 billion cancer cells. And 4 years means that the whole body is connected through bloodstream, through lymphatics, etc.
Yes.
So our PET CT scans cannot pick up anything less than a centimeter or 0.5 centimeter. So, when there are 1 million cells
Yes.
or 10 million cells, no CT scan, PET scan will be able to pick up. But ctDNA can pick up the tumor in the body at that point in time. So, one is detecting minimal residual disease with the ctDNA. The other technology which is coming up is methylation based.
Yes.
So, labs like Guardant and certain others, they are now doing, minimal residual disease detection by, methylation patterns of the DNA being studied from the peripheral blood. Yeah. So this is actually called tumor agnostic approach, where whether one has lung cancer, kidney cancer, breast cancer, gallbladder cancer, the test is the same.
Okay.
The other test, which is called the tumor-informed approach to detect the ctDNA or minimal residual disease, which is, I believe, more popular. For example, Signatra or Natera and certain other labs are doing it.
Right.
So how they do it is, so you need the tissue in this scenario from the primary tumor,
Right.
and then you do whole exome sequencing, and then you identify about 16 to 50 important genes which are present in that tumor.
Yes.
So your 20 genes are identified.
Correct. The highly enriched.
And then, so those 20 genes you focus on for ultra deep sequencing.
Correct.
Because you have to do very deep sequencing. Almost you have to go to 0.01 or 0.001 level. Right.
Yes.
So this is the tumor informed approach.
Okay.
So both the approaches are there at this point in time, and we are actually using these techniques. The labs are providing us in clinic as well.
Very nice.
So it has started to appear in the clinic. I can give you an example. For example, in patients with urinary bladder cancer, when it's early, the treatment is to remove the tumor. They operate upon the patient, cystectomy, or the bladder is removed. And now the issue is, after removal, we are supposed to give them adjuvant chemotherapy to kill the microscopic cells, which cannot be picked up on the PET scan or CT scan.
Right.
So, so what they did was, they, took about 700 patients, and then they operated on all of them.
Right.
And then after the surgery, about a month later, they did the ctDNA MRD testing.
Okay.
All right. So they were like half of the patients are ctDNA MRD negative. So there was no tumor seen in or no DNA fragment seen in the peripheral blood.
So, sir, can you give a clinical example where MRD testing has really changed the patient management scheme?
Yeah, so absolutely. There are several tumor types where ctDNA is making a material change in the management. I'll give you a few examples.
Yes, please.
So one is a patient with breast cancer, hormone receptor positive, and this patient is taking hormonal therapy in the adjuvant setting, which means that the patient had surgery done, chemo done, and we were giving them, a hormone pill.
Okay.
So now they did a study on about 1,000 ladies, and they started collecting their blood sample for looking at MRD, ctDNA test, right? And they found that some women started becoming ctDNA positive after 1 to 2 years.
Okay.
So then this patient is on, say, one hormone. So the thought process is that you escalate your hormonal therapy to a CDK4/6 inhibitor and maybe a better SERD, as they call it, which is a type of drug. So you are escalating the treatment based on ctDNA. If it was found positive in a woman who was PET scan was normal, she was absolutely fine. So this is called a DARE study. So this is become available now. Similarly, we have another scenario in which patient has metastatic disease, hormone receptor positive, and patient is continuing on a CDK4/6 inhibitor and a hormonal therapy. And now some of these women, they develop ESR1 mutation, so which is responsible for relapse. So either you wait for relapse to happen, or you intervene when you just find it through your MRD testing, the ESR1 mutation, the level of which is rising. You can quantitate this actually. You have tools in the genetics lab to do this. So based on the ESR1 mutation, which became positive, who was doing well, she had no symptoms. PET-CT is normal. They escalated to a better drug, a SERD, which is like camizestrant, which is called. And they found that these patients are doing better than as compared to where you did not put them on camizestrant. So in breast cancer, in the adjuvant scenario, in the metastatic disease, you have these patients who are deriving benefit from escalation of the treatment. Similarly, in the adjuvant setting, when surgery has been done, we are giving the treatment for prevention purposes. So patients after surgery, if their ctDNA is negative, means MRD is negative, can I avoid chemo? That's the question. So in colon cancer, a lot of trials have been done all across the world, in Japan, in US, dynamic study, galaxy study, and so on. And there is a very strong data which is emerging that after having done the surgery, you do the MRD testing and stage 2, 3, resectable disease, curable disease, to avoid chemo. So and just doing the ctDNA MRD, one can take a call on a patient whether or not to give chemo. So you're not only talking of escalation, as I said before, you can even think of de-escalation and avoid the side effects of chemotherapy in patients with colon cancer.
So one question, as you mentioned, being done in Western countries, so any data being available in Indian population, Asian population, or we are doing it for the first time in Gangaram Hospital?
So the ctDNA testing is a costly test. So at the moment, the test is costing around 3 lakhs per test or so, in that range.
Quite high.
But you'll be delighted to know that in the next 2-3 months, I think a couple of labs are going to come up with the Indian MRD testing through ctDNA. So I think that is going to be, we are just pushing these labs to, actually when you do the ultra deep sequencing, there's a lot of reagent requirement, there's a lot of bioinformatics, so which makes the test costly. But I think in order for it to reach the masses and the clinicians and the clinicians taking benefit, it has to be in reasonable price. 3-4 lakhs is no price for average or a middle class person. So it has to be within the range of 30, 40, 50,000. But I think, I'm sure, when we started doing NGS, they started, the cost was 5 lakhs.
5 lakhs.
And today, I mean, good labs are doing this test at 40 to 50,000, 1/10 the price. So the technology is becoming simpler, reagents are becoming simpler, the demand is increasing. So when the numbers increase, the cost drops. So I think the understanding of this whole test of doing the NGS, ultra deep sequencing, whether it is ctDNA based or it is methylation based, is really going to be changing the outcome, changing the way we look at cancer, because you're picking up the disease in the body at 1 million or 10 million cells as compared to 10 billion cells. So there's a lot of heterogeneity. As these tumor cells divide, they acquire more and more genetic mutations and they become more and more difficult to treat and cure. So at the moment we need more effective targeted drugs, more effective immunotherapy tools, maybe better chemotherapy tools, so as to kill the tumor cells early, permanently, at a time when the tumor load is 10 to the power 6 or 10 to the power 7. So these are very deep analysis of cancer patients or cancer cells. Let me just put it, because a lot of people may not understand this, but I think the scientists, the students who are into molecular biology will have an understanding. And I strongly feel, in fact I wrote in one of the newspapers that there is going to be a paradigm shift from imaging to blood testing, which is a liquid biopsy. Because you're able to pick up the tumor cells. I mean, unless the PET CT scan people, they identify 1 millimeter or 0.5 millimeter testing. But ctDNA is there. And that is definitely going to be helping us in diagnosing and picking the cancers early.
So I think both the biomarker molecular signatures, as you are mentioning, along with the imaging, that can give us a holistic overview of
but imaging is later.
Still later.
9 months later.
Detected as
1 year later. So I think we move on to one more aspect of this. This is MCED. That is the multi-cancer detection. So the study, which is the GRAIL study or the Gallery study, which was conducted in UK on 150,000, so 1.5 lakh individuals, in which they took 70,000 normal people who were tested once a year with a blood test, and this is a methylation based test where they take the blood sample and they can, based on the methylation patterns, they can predict that this patient may develop lung cancer or gallbladder cancer, etc. So this test picked up a lot of stage 3, stage 4 and even stage 2. It did not meet the hazard ratio and the p-value, but I think this is the future, that on the basis of a blood test you can predict in a given individual whether 2, 3, 4 years down the line he or she is going to develop cancer or not. It sounds scary. I mean, if I were to do a test today and they tell me that 3 years down the line I'll develop cancer, so but then but then 150,000 people participated in the trial. So they subjected themselves to that kind of study. And I think similar studies, I think in India also we have methylation based test which is also available readily and at a very nominal price, but then I think the take is not much. So it's simpler in the sense you just have to give a blood sample. So like you do your other biomarkers, like your PSA test for prostate cancer, CEA for colon cancer, CA 15.3 for breast cancer, CA BRCA 125 for ovarian cancer. So, but these tests are so very deep into the, molecular understanding of the cancer than as compared to these blood tests, other blood tests which are readily available. So I think the molecular biology is there to be understood, to be put into practice more in the future, and it's happening actually.
So one thing, as you just mentioned, Dr. Agarwal, like these biomarkers may act as early prognostic biomarkers, which may help predict the cancer at a very early age.
Yes.
So where do you think, as with the upcoming, multi-omics, as we all know these days, and AI, which is, much more very attractive to the students out there, to the researchers, and even the clinicians. So how you think the India's healthcare system is ready for this transformation? How we can integrate both multi-omics and AI together to help diagnose the patients in a better way?
So absolutely. So I am, for the last 1 to 2 years, have been telling our research department, and not only ours, but since we meet oncologists across the country, whether it is Tata, whether it is All India Institute, whether it is Rajiv Gandhi, and so on. So I think we have to perform India-centric tests. And as I said, a couple of labs, in fact 3 or 4 labs in our country, they are building their own data sets. And I think AI is going to make things easier, because once you put more and more data, the AI will have the learning capabilities, because it has. So once it goes into the equipment, goes into the machine, so it stays stored. Human being can forget, but the computer is never going to forget. So AI is also going to be helpful in a big way to analyze the data which we are putting in for the molecular biology of the cancer. But I think the labs have to design some trials based on, now for example, in a triple negative breast cancer who is BRCA1/2 positive, again, just on the basis of BRCA1/2 positivity, you can decide whether the patient has relapsed or should be given PARP inhibitor or not. So there are several markers which can be incorporated in the day-to-day practice for patients with a variety of cancers.
Correct. Correct. So sir, as so many patients and their families, they just walk into your clinic. So they are, they have lot many questions. They keep, these days, AI and all these chat GPT and all algorithm based softwares are there. So they keep searching. So I think they are over-informed, they are over-aware. So they have many questions when they come into. So there are few, audience questions we would like to ask you. So one is like, does having a genetic mutation mean I will definitely develop cancer?
No, it's not a single gene mutation, which can lead to cancer. So mostly it's multiple mutations. And as I said, that, the methylation-based, GRAIL test, that's the only test which can predict having cancer. One gene mutation, for example, say if somebody has BRCA1, BRCA2, I mean, we all give this example of Angelina Jolie. She on the basis of that, she never had breast cancer. So on the basis of that gene, if somebody has BRCA1, BRCA2, then she has a 70, 80, 90% lifetime chance of developing breast or ovarian cancer. So what did she do? So she was scared of cancer. So she got her breasts removed, because if you don't have the breasts, then no breast cancer. And subsequently she got her ovaries removed. So BRCA1/2 is one example. If that is found to be mutated, well then there's a lifetime chance. So it's not an emergency thing, but then maybe after completing your family, one can think of bilateral mastectomy and bilateral oophorectomy, but there are other methods also. But barring that, I mean, Lynch syndrome is another MSI based gene, in which families and people have a high incidence of developing a variety of cancers. So there are select genes. So it's not that if you find any particular gene mutation, PIK3C or P53, etc. So those are some very, very niche genes where you can develop cancer. So you have to look at the gene and then answer the person.
Fine. So second question, if my biomarker is negative, as you just explained about biomarker, so does that mean there's no treatment for me?
No. So biomarker helps adding on to the existing guidelines. So for example, chemotherapy can be given to all. So our algorithm is based on a lot of work which has been done in the last 40-50 years, and the first thing to start in 1945 was chemotherapy, and we had methotrexate, and now we have more than 200 drugs. So these targeted drugs have come only in 2002 and beyond. So for 50 years or so, we were treating patients with a variety of chemotherapy drugs. And let me say this, new chemotherapy drugs are also being discovered. So we're not supposed to discard chemotherapy. So every modality, whether it is chemo, whether it is targeted drugs, immunotherapy, and now we have ADCs, antibody drug conjugates. So,
they all have their own importance.
Absolutely. So depending upon type of cancer, each cancer is different.
Yes.
So there are 200 types of cancer in body. So each treatment is going to be different. We have CAR T cells for lymphoma and for ALL and for myelomas. So, multiple modalities, and each patient is different, and therefore depending on his or her stage, economy, and performance status, etc., we have to go by the guidelines.
Okay, so I come to the third question. Can a blood test really replace a tissue biopsy?
Not at the moment, but once the labs, the genetic labs, or the deep sequencing labs become more and more effective.
Yes.
But there are a few labs actually, they don't do tissue tests.
Okay.
They started doing blood liquid biopsy, and they have got the maharat in that.
Okay.
And there's and they are very confident.
They're very expertise.
They have developed their expertise.
Yeah.
But at the moment, by and large, especially labs in India and even abroad, we are banking on tissue. But if you don't have tissue, then I think liquid biopsy is not far behind. It's almost as good and sometimes even better. So complementary, tissue and liquid is more helpful, but I'll prefer tissue at this point in time.
Okay. Yeah. So the other question, should everyone undergo blood-based multi-cancer early detection tests like Galleri, as you just mentioned?
So that is still in trial at this point in time. There is no recommendation or guideline to do this test. But then, in some people who may be having a high incidence or high probability of developing cancer, for example, somebody is a smoker and is smoking for 30-40 years, or somebody is at a high risk as a family history, very strong family history.
Yes.
So those are the people who can go for this test, but I think it's not available in India at this point in time.
Okay, fine. So what can individuals do today to reduce their cancer risk?
So cancer is supposed to be a lifestyle disease because alcohol, tobacco, sedentary habits, obesity, lack of exercise, lack of fruits, vegetables in the life leads to development of cancer. So you have to have a very, very fit lifestyle to keep cancer away. But that doesn't mean that a person who is jogging or who's running and whose BMI is 25 will not develop cancer. Yes. But yes, there is clear data emerging, which is actually established that obesity is one reason why people are developing more and more cancers. And let me add here, there were recent WHO and ICMR estimates that 2050, the cancer is going to double in numbers.
Oh, really?
Yeah. Just 5 days ago, there was a declaration from WHO that in spite of our understanding of tobacco, alcohol, obesity, by 2050, the number of cancer whom we diagnose today will be twice as much.
So will it be because of lifestyle changes?
So lifestyle is one, pollution is another, then global warming possibly, is another, lack of ozone or, more UV rays. So we don't know the exact cause. But then these are the issues which are happening, and cancer is on the rise.
Oh my God. So are the technologies for treatment
of course.
cancer?
Yeah. So the beauty is, so we are telling our cancer patients that with the availability of these newer techniques, whether it is molecular biology, targeted drugs, immunotherapy, surgery, robotics, PET CT scans, we are converting this disease into a chronic disease.
Yes.
People who were living for 1 year with a lot of toxicity from chemotherapy are now surviving 5, 10 or even beyond that years. So we are converting this disease into a chronic disease like diabetes and hypertension. So don't be scared of cancer. So go to your doctor and find the best possible treatment for yourself.
Thank you so much. And one last question. How close are we in making this precision oncology available to every patient out there in India?
Right. So as I said, 10 years ago, the cost of that NGS was 5 lakhs.
Yes.
Today, I can even get the test done at 30,000-40,000. So things are becoming easier, but ctDNA MRD is still going to be expensive. I don't know the cost, which is going to be rolled out in the next couple of months. But I think people are beginning to understand the biology, molecular biology, molecular oncology, and the labs have mushroomed in our country. I mean, you have more than 200 labs, and each one is trying to do their own tests, do their own standardization, so as to reach the common man, the common masses, to provide the benefit of this test, whether it is NGS, whether it is CT, DNA, MRD, or whether it is MSI, immunotherapy based test, PD-L1, etc. So the labs are mushrooming, the targeted drugs are coming in, immunotherapy is coming in, so more and more modalities are emerging so as to keep the disease in control for long periods of time for a common person.
As just mentioned, to term it as a chronic disease rather than a very deadly disease we are all scared
of. And let me also add here, it's not that we convert into chronic disease. If you detect cancers early, you can cure them. So in the US and in Europe, 100 patients diagnosed today. Can you tell me how many will be cured? Any guess? 10%, 20%, 40%?
Maybe, I think 20-30%.
So wrong.
Okay.
So the technology, the ability, the literacy, early testing, early detection, 80 out of 100 Europeans or Americans will be cured today. In India, that figure is 40%. Because in India, the cancer is detected at a late stage. Because they don't come to the doctor in time. So early detection is curing 80%. So if there are 100 people who are developing cancer today, 80 will be cured.
Very important message.
So 80 will be cured. So India should go from 40 to 80. So that will be my dream come true. And once you have more and more tools, that figure can be 90 actually, right? So I think early detection
maybe
is
sometime later in 20, maybe 60, 70, we may demolish this cancer.
I don't know. I mean, that's like, a dream come true.
Dream come true.
If we can diagnose cancer even at late stage and say that this patient all people will be cured. So I think that's cancer is very smart. Because they evolve, the genes which they start with, they change in 6 months, 1 year time. But now that ability of the gene testing to pick up those gene alterations and target them is increasing day by day, and that is why we are able to convert these chronic disease, for cancers as well. So I think we've learned a lot in the last 30-40 years, and there's a lot more to learn. And so that we can, detect them early, cure them, if not cure them, control them for long periods of time.
So one last message to all the young researchers out there. So any message you would like to convey to them?
So, you need to be in a good lab. You need to focus on the, not only the DNA part, not only the, the epigenetics part, but I think, you have proteomics, we have not discussed, fragmentomics.
Maybe next episode we may update.
So there are multi-omics. So you need to focus on the cancer cell so as to, you really have to get into the lab. And cancer will give you so much in terms of understanding that your life will be full, and you need to, it's really an enigma. Cancer cell is an enigma, and this is what God has given to all of us, that these cancer cells, they change their character in few months' time, and then we are targeting the other gene. So I think you need to focus on one aspect and excel in that, and that's how people have developed newer and newer, targeted drugs, immune therapy, and so on.
So thank you, Dr. Agarwal. It's really been our pleasure to have you with us on this talk show, where you have discussed your 4 decades of clinical expertise, how you have seen the evolution of conventional chemotherapy to targeted therapies and immunotherapy these days.
Absolutely.
So I think at Sir Gangaram Hospital, we are working in a closed niche where all the clinicians, researchers, young scientists, and even genetics, like all the people from who are immunologists, pathologists, who all are working hand in hand to help diagnose this disease at a much earlier stage, so that we all can come together and help our best to keep the front foot forward so as to cure the disease. So thank you so much, sir.
Thank you, Dr. Evanka.
Thank you so much. Thank you.